and she graduated in the clinical nutrition program in Kingston University 2015. And she also has a master's degree in medical education from King Saud bin Abdulaziz University for Health Sciences in 2017. So this is really the second master's degree in her career. So we have a very active student. Thank you, غادة, for all of the previous years of work. Now the day, and you have to present the best of your work in this presentation. You will have 20 minutes of presentation. Then we'll have 5 minutes for general questions and the secret discussion. غادة, please, the stage is yours.
Thank you so much, Dr. Mahmoud, for your kind words and great introduction. I am غادة Mjali. I will be introducing and defending my master thesis, Nutrition Care Process Documentation in Obese Children and Adolescents with Metabolic Syndrome and or Non-Alcoholic Fatty Liver Disease in Riyadh. I would like to first acknowledge my supervisors, Dr. Mahmoud and Dr. Dara Desi. Without their supports and continuous assistance during this master thesis, I would not be able to complete it. Of course, I would like to also acknowledge the assistance and support I received from Dr. Iqab Al-Utaybi, Dr. Mu'abbar Mahzari, and Dr. Hussein Sagaf for helping me collecting the data and extracting the subject from the hospitals that we included in the study. I would finally thank Ms. Ra'ad Mjalli for her assistance in collecting and entering the data and cleaning the data. I will be presenting the introduction for my master thesis and moving to the methods, results, discussion, conclusion, and finally references. The first topic in the introduction is dietitian documentation in healthcare settings. Improving the quality of documentation in healthcare settings has been an ongoing process because of the increasing rate of preventable medical errors that was a result of poor quality documentation. There was a call for increasing the quality of documentation. When we improve the quality of documentation in healthcare settings, we improve the patient safety and increase the efficiency of interdisciplinary healthcare teams and the communication with other healthcare professionals. Dietitians have several types of documentation. Major types are the SOAP notes or subjective objective assessment and planning. There are also old and no longer used documentation types, such as focus charting and charting by exceptions and process-oriented approach. In the recent years, there was a call for unifying nutritional charting forms due to the various types and methods of documentation. In 2013, the American Dietitian Association has set the following goals: to increase the demand of nutritional services, increase the utilization of ADA members, and empower dietitians to compete in the ever-changing environment of healthcare. Based on those goals, they established and implemented the standardized nutrition care process. This process is defined as a systematic problem-solving method that dietetics professionals use to critically think and make decisions to address nutrition-related problems. This provides a safe and effective quality nutrition care. Nutrition care process steps include nutrition assessment, nutrition diagnosis, nutrition intervention, nutrition monitoring, and evaluation. After the development of the nutrition care process, the ADA developed also a new format of dietitian documentation to document the NCP steps, and it was abbreviated according to the steps themselves, or ADIME. They also developed international dietetic and nutrition terminology reference manual, bringing a long-awaited standardization into the dietetic practice. This figure shows how the SOAP, the most common form of dietetic documentation, has been transformed to ADIME. It's basically subjective to nutrition assessment, objective to nutrition diagnosis, assessment to nutrition intervention, and plan will be divided into nutrition intervention and nutrition monitoring. There are several studies that focus on implementing NCP in practice. In 2005, Hackle, Smith et al., they compared between two hospitals. Hospital A enforced a routine education of NCP and orientation of the process, while Hospital B only provided orientation. And they found out that regular reinforcement increased the documentation of the steps. Other study performed a retrospective audit on 147 outpatient dietitian notes, and they put them in 3 levels. Level A, which is a high score, level B is a medium score, and level C is a low score. The audit results showed that the documentation level falls in level B mostly, and also only 3% of the notes scored at level A. The most frequently documented item was nutritional intervention, while the least was problem etiology symptoms. The last study was done in 2017. It was a cross-sectional survey that distributed among dietitians and managers of dietitian departments, skincare nutrition departments, sorry. They found out that the key element of sustaining NCPT implementation is ongoing management support, NCP targeted workshop, and bucket guides. The dietetic manager's opinion differed around the usefulness of NCPT in improving patient care and facilitating staff communication. The second topic's introduction is metabolic syndrome. It has been a rising epidemic with a worldwide prevalence ranging from 6.5% to 10% and increasing to 30% in overweight pediatrics. It's been considered a risk factor for type 2 diabetes and cardiovascular disease, and it's most recently been associated with non-alcoholic fatty liver disease. There are several risk factors for this disease, such as sedentary lifestyle, high body mass index, and high calorie diet. It has many definitions in the literature for pediatric populations. However, there is currently no uniformly accepted definition of metabolic syndrome in pediatrics. But the main criteria for metabolic syndrome definition are central obesity, insulin resistance, dyslipidemia, high visceral adiposity, elevated blood pressure. The third and final topic in the introduction is non-alcoholic fatty liver disease in pediatric. It has been linked with obesity and metabolic syndrome, and it's now considered the hepatic manifestation of metabolic syndrome and an important public health concern. It's now considered the most common cause of chronic liver disease in children. And it is defined as the presence of fat in liver parenchyma without inflammation or hepatic steatosis. And evidence of hepatic steatosis should be either by imaging or histology. There are several risk factors associated with NAFLD, such as insulin resistance, hypertension, and cardiovascular disease. It has been found that in child obesity clinics, the mean percentage of metabolic NAFLD is 34.2%. And so far, there are no studies that estimated the prevalence of NAFLD among the COD pediatric population. To diagnose NAFLD in children, we first suspect NAFLD in children with risk factors, mainly obesity, and we diagnose it using abdominal ultrasound and liver function test, followed by exclusion of other liver diseases. However, if the results is normal, we usually monitor the overweight and obese children. To confirm the stage of the disease, we have to perform liver biopsy. However, due to the several limitations such as cost and procedure-related morbidity and mortality, it's difficult to apply it in clinical setting. The study rationale was because weight management and nutritional intervention is the first taken approach for treating obesity, metabolic syndrome, and non-alcoholic fatty liver disease. It is important to follow recent implemented nutrition care process, systematic approach to reach an individualized nutritional intervention for those patients, and to accurately document the process in the dietitian notes. In Saudi Arabia, there are no studies that aim to evaluate dietitian documentation and its effect on nutritional outcomes in obese pediatric patients diagnosed with NAFLD and metabolic syndrome comorbidities. Therefore, our study is critical as it evaluated the NCB documentation in Saudi Arabia for this at-risk population. The study has two aims. The first one is to evaluate the NCB documentation and medical records of the Saudi hospital for obese pediatric and adolescent patient diagnosed with metabolic syndrome and or NAFLD, and to evaluate the impact of the NCB documentation on nutritional goals achievement. The study objectives were systematically collect the electronic dietetic notes from tertiary care hospitals for obese children and adolescents diagnosed with NAFLD and or metabolic syndrome, perform a retrospective audit of the collected dietetic notes using a validated audit instrument, compare audits results of the NCB documentation in 3 tertiary care hospitals in Riyadh, and finally document the progress of nutritional goals achievement parameters from the electronic medical records for obese pediatric and adult patients diagnosed with NAFLD or metabolic syndrome. Our hypothesis was that there is a positive impact of high quality dietetic documentation on the achievement of nutritional goals. Moving to the study methods, the study setting was in King Abdullah Specialist Children's Hospital, CASH, Security Forces Hospital, and King Khalid University Hospital. The study was a retrospective cohort study where data were retrieved from hospital medical records between 2014 and 2019. The study subjects were obese patients aged 8 to 18 diagnosed with NAFLD or metabolic syndrome. Subjects were included in the study if they were male or female pediatric diagnosed with obesity, obesity associated with NAFLD, obesity associated with metabolic syndrome, and finally, obesity associated with both NAFLD and metabolic syndrome, and we put them in the following groups. Inclusion criteria were NAFLD diagnosis followed the definition of definitive NAFLD, which is the fat presence in the liver parenchyma, and the diagnosis must be done by diagnostic imaging or liver biopsy. And the subject must have specific parameters in the record to evaluate metabolic syndrome within 6 months of NAFLD diagnosis. We excluded patients with history of parental nutrition, bariatric or hepatobiliary surgery, human HIV infection, metabolic acidosis, renal dysfunction, and short bowel syndrome. After taking the IRB approval of from those hospitals, we searched the hospital database. However, due to the different systems implemented in the hospitals, we used different keywords for each system. And we followed a consecutive sampling technique where we included all the subjects that followed our inclusion and exclusion criteria. The estimated number of subjects needed for the study was 200 obese patients with or without the complication of NAFLD and metabolic syndrome. We included the following parameters. The first parameters included socioeconomic data and medical history, where we included gender and medical age and medical history. And medical history included the patient diagnosis and current medication. Obesity parameters included weight and height to calculate the BMI. We also included the obesity diagnosis method. Metabolic syndrome parameters, we evaluated the metabolic syndrome based on the adult treatment panel definition, modified criteria for pediatrics, including obesity, hypertension, abnormal glucose homeostasis, and dyslipidemia. If the subject has 3 or all those criteria, then we will consider them metabolic syndrome patients. For NAFLD, we took the NAFLD diagnostic method, the stage of the disease, and liver function test. Those were based on the physician reports and radiology reports and pathology reports. Assessing the quality of dietitian documentation was based on using diet NCP audit, which is a validated audit instrument, and the nutritional goals achievement parameter was based on the improvement of the above mentioned parameters. The progression of the disease was based on, after grouping the subject and the 4 groups, we did a pair t-test and Friedman ANOVA to show the difference of mean between the variables collected in 3 assessment periods. The first period will be the baseline, the second period will be after 6 months, the third and final periods will be after 12 months from baseline. The total score of audit tool will be, the score will be put in 3 levels, level A, which is high, level B is medium, and level C will be the low score. T-test was performed to estimate the difference between the subject with reported dietitian documentation and subject with no reported dietitian documentation. Estimating the effect of the level of dietitian documentation was done by comparing between the 3 levels of dietitian documentation, and we did a correlation test between the achievement of nutritional goals and the scores of dietetic documentation. The study included 142 subjects. They were divided into 4 groups. Group 1, which is obese patient, included 37 subjects. Group 2, obese with subject with NAFLD, included 74 subjects. Group 3, obese with metabolic syndrome, included only 10 subjects. And the final group, which is obese and metabolic syndrome and NAFLD, included 21 subjects. From CASH, we included 68 subjects. From King Khalid University Hospital included 38, and Security Forces Hospital 36. After reviewing the patient record, we found out the most commonly used diagnosis method was sleep. After reviewing the baseline characteristic of subject among the groups, we found the difference was apparent in the body mass index, glucose, and ALP. After comparing between the groups based on between the 3 assessment periods, we found out that in obese group, the BMI was significantly different. In the obese patient with NAFLD, the BMI also was significantly different, and ALP was also significantly different. However, there was no difference in obese patient with metabolic syndrome. In the final group, obese patient with METS and NAFLD, we found out the difference was significant BMI and LDL. After reviewing this, or auditing the dietitian documentation, we found out that only 58 dietitian notes were found in the patient file. CASH has the highest number, which is 36, and their level was mostly level A, which is the highest. King Khalid University Hospital and Security Forces Hospital scores were mostly on the B and C level. T-test was performed to compare between the subject with reported dietitian documentation and the subject with no reported dietitian documentation, and we found there is no difference. However, when we compared between the level of dietitian documentation, we found out there was a significant difference in the systolic blood pressure, LDL and FBG, and bilirubin. When studying the correlation between assessing the correlation between dietitian documentation audit scores and the achievement of nutritional goal among groups, we found out that there is a significant correlation between the scores and body mass index in obese patient with non-alcoholic fatty liver disease and ALP. However, when we did the correlation among all the groups, we found only AST showed that negative correlation with audit scores. Moving to the discussion part, the study shows that there is a severe lack in dietitian documentation in patient medical records, with more than half of the documentation level falling in medium and low levels and 2 of the major tertiary hospitals scoring mostly level B and C in the audit documentation. The study found there is no significant difference in the progression of disease parameters between subject with reported dietitian documentation and subject with no documentation. However, the significant difference was found in DP, that's the systolic blood pressure, LDL, fasting blood glucose, and bilirubin. The high scores showed in the result were not consistent. High scores of audit scores showed in the results were not consistent with the results of the previous study that utilized the tool and developed it, where they found that 98 of the dietitian notes scored in the B level and C level. The deficiency of documentation might be explained by Al-Khalidi et al. Survey study, where they included the dietitian and assessed their opinions and interprets that they found out that the knowledge that more than 98% of the dietitians have knowledge of NCP. However, only 27% of those dietitians received training in implementing NCP. And they found out that the dietitian opinion of why it's difficult to implement it was the lack of practical experience and the different systems between the NCP and the hospital systems. This study is supported by also research that aimed to implement and monitor NCP in dietitian practice. In previous research, they found out that it's very critical to orient dietitian to NCP and to monitor the practice via chart audits. Additionally, in the previous study in the team that developed the tool, when they investigated the dietitian in countries with more experience in implementing NCP, they found out that its clear implementation strategies has had a higher level of implementation of NCP. Qualitative study aims to explore also their study focus on the dietitian experience in implementing NCP process in different settings, concluded that due to the difference in the setting, it should be taken into consideration to tailor the NCP process and format according to the hospital setting. While King Khalid University Hospital has recently implemented NCP and ADINE in their system, there is no documented implementation strategy utilized for implementation and monitor the practice. The low results shown in King Khalid University Hospital and Security Forces Hospital audit scores suggest that implementation strategy of NCP needs to be revised and tailored to fit the setting in both hospitals. Another interpretation of low scores of audit might be that the small number of dietitian documentation found in the subject file in King Khalid University Hospitals and Security Forces Hospital compared to cash might have contributed to the low scores. The second result was related to the correlation and association between the audit scores and dietitian documentation, of nutritional outcomes. In the literature, we found only focusing on malnourishment and improvement of malnourishment in patients. And in similar studies, similar to this, they found out there is a positive correlation between the quality of documentation and the level of documentation and improvement of malnourished patients. There are several limitations to the study. Due to the relative rarity of those diseases in the pediatric population, it only led to finding a small sample size. And it makes generalizing the results of the study difficult, and it has led to some non-significant results in the correlation test. Furthermore, the transition of medical records from paper-based record to electronic system led to difficulty tracking subject further than 2015 in CASH and King Khalid University Hospital. However, in Security Forces Hospital, it is a paper-based scan system of healthcare providers' documentation. In conclusion, the study showed that there was a severe lack of dietitian documentation among the study population, which are in critical need for nutrition intervention, since the obesity, NAFLD, and metabolic syndrome are diseases that are first tackled with nutritional intervention. One explanation of this result can be the lack of adequate training, tailored implementation strategies, and reinforcement of NCP documentation. Another reason could be the recent transition from paper-based documentation system to electronic documentation system and difficulty implementing NCP in this system. The study also found that the level of dietitian documentation was high in only one hospital, while most scored a medium and low score in other hospitals. The audit tool utilized for assessing the level of dietitian documentation was designed utilizing NCP, which was only recently implemented in Sautia Hospital. The low levels can also be attributed to the transition from SOAP notes to ADINE. The study also found that there is association between the quality of dietitian documentation and patient nutritional outcomes. We recommend further research should be done to investigate the level of dietitian documentation and the association between the quality of this documentation and nutritional outcomes, and also to explore the reason behind documentation deficiency among dietitians and current strategies utilized to ensure proper implementation of NCP in clinical practice. Those are the references utilized in this presentation. Thank you.
Thank you, غادة, for this excellent presentation. Again, I need to welcome Professor Ali Al-Mijwal and Professor Mohammed Shrakawi, and Dr. Dara and Dr. Khaled Al-Muteri. Now we should receive some questions from the audience. From live chat, we don't have any question, just greeting the work of غادة. So if Professor Ali or Dr. Mohammed Sharif Sharkawi need to ask some question, then we shift to the secret room to have the secret discussion.
So I can leave to Dr. Ali because this is his, his field. So I'll be after him.
السلام عليكم.
وعليكم السلام.
المعذرة في البداية أنا تأخرت بسبب تكنيكال إيشو ما أدري شو اللي صار لكن ساعدوني الزملاء. First of all, I would like to thank Ada for this very good presentation, and I just have one question for you, and then we will move to the discussion with the committee. My question is related to what are your main subjects? You are assessing the documentation of dietitians. So your subjects are the dietitians or the patients? What do you think in the main subject? You have to, but the main thing that you are doing is assessing the documentation. The documentation is for dietitians. But I noticed that you focused on patients. Can you just clarify this issue?
Thank you for your question, Prof. Ali. Regarding the subjects of the documentation, the focus was on auditing or assessing the quality of documentation of the nutrition care plan for the patient themselves. So what we did is review the dietitian notes that were taken during the visits. And according to the audit results, we scored the dietitian documentation itself from level A, B, and C based on the quality of it and the writing of the documentation. After that, we compared between the hospitals, the audit scores between the hospitals. The final or the main results were that we wanted to see the effect of this quality of documentation of nutrition plan for the patients on the patient's outcomes and improvement of the patient parameters. I hope this clarifies.
Another question, غادة. What's the reason, what's the rationale behind choosing this group? You choose the obese children, adolescents, metabolic syndrome. Are there any, because you are assessing the documentation of dietitian, are these diseases will affect the documentation, not similar to other diseases, or why you selected these groups?
Okay, thank you. So the reason for choosing this group is those three diseases are mainly tackled by nutritional intervention. So what physicians do when they are facing patients with metabolic syndrome, non-alcoholic fatty liver disease or obesity, they are referring them to dietitians. They don't give pediatric patients medication for NAFLD because NAFLD is usually left for treatment by nutritional intervention, similar to metabolic syndrome, which is underdiagnosed disease actually, and they usually don't suspect or don't diagnose pediatric with metabolic syndrome. Obesity is also a nutritional diagnosis for the patient, where they are treating it also by referring to the dietitian. So what we are doing in this study is tackling issues that usually handled by the dietitian themselves. And we want to see if the care plan that is documented in their documentation can reflect the improvement of the patient parameters.
غادة, my last question is, have you considered the confounding factors? Dietitian documentations or the documentations sometimes affected by other factors, such as the experience of dietitian, level of education. There are many factors that may affect their level in documenting the case. So have you considered that?
That's actually a great question, Prof. Ali. The tool itself is testing the major steps that a dietitian takes. So if I'm evaluating the tool, I usually don't go through what we say a lengthy. We're not concerned about the length of the dietitian notes. The items that usually score on the language, of the writings, those usually are the ones affected by the level and experience. But the major items concerning how they are drafting the nutrition plan, for example, or how they are drafting the evaluation for the patients, or how they are monitoring the patient. This should be a basic requirements for dietitian documentation. Because if I'm expecting the dietitian to put or give the patient a full consultation, it should be documented. So in future references for other dietitians who are monitoring the patients, or adult healthcare providers who want to see how is this patient being treated, we expect the documentation to reflect a clear plan and a clear care plan for this patient.
Thank you, غادة. Good luck.
Thank you, Professor Ali. This is a very interesting question and really represent the great experience in the field of clinical nutrition. Now, Professor Sharif, if you need some question.
Assalamu alaikum wa rahmatullahi wa barakatuh. Actually, I'm very happy. I'm proud to be in this committee, and thank you very much for inviting me. One of the big problems that we meet in researches, or actually two problems, are data collection and documentations. And when we start to write our researches, we will find out a lot of problems in these two parts. So they need to be standardized and optimized so that you get good results. I have some notes which are actually few, and if I can, I don't have questions, so I can move to some points, or we need to make the points later on.
It is general questions for general, because it is now in live. So if it is just secret points or points for examination, should be delayed to the secret discussion.
Okay, so I'll keep it later on. I don't have.
Yeah. If general question, okay.
Okay. So I'm finished with questions. I mean, I will keep my points until we go for discussion.
دكتور محمود الصوت